Rahul, can you hear me?
Yes, sir, I can.
Samit, you are on.
Yes, sir.
Sir, today, am I audible, sir? Sir, am I audible?
Yes, you are audible.
Oh. Sir, today presenters will be Dr. Jeena Priya, Dr. Samit Doshi, and Dr. Ankit Gupta. Dr. Ankit Gupta will be joining in 1 minute, sir.
Good evening, Dr. Venkat.
Sir, good evening, sir.
Hello. Rahul, who is answering today?
Sir, today Dr. Ankit Gupta, Dr. Samit Doshi, and Dr. Jeena Priya are answering.
Okay. Mahendra Pal is joining. Dr. Gite has already joined. Amandeep will take some time. He has got some emergency. Ganesh Bakshi has confirmed he is joining. I think we start now.
Yes, sir, we can start.
Yeah, Mahendra, you joined. Good. Rahul. So today, Mahendra, three people are answering: Samit, Ankit, and Jina.
Okay.
Rahul.
Sir, screen is not there.
Yeah. No, I think Rahul has got some. Okay.
Can we start, sir?
Yeah, start.
72-year-old male presented with chief complaint of increased frequency for the last 6 months, nocturia 4 to 5 times per night since last 6 months, and incomplete voiding for last 1 month.
Fine. Jina, these are the, I think you are answering for the first time.
Yes, sir.
So these are the history. Now, how will you elaborate? So
Sir,
what
I
are the
will,
questions you want to know?
sir, I will ask the other LUTS symptoms also, the obstructive and voiding symptoms, which include urgency and urgent incontinence for the storage symptoms, I mean voiding symptoms, and then storage waiting. And then intermittency, hesitancy, and hematuria, any dysuria, any lithuria, any calciuria. And has he consulted any prior for the same symptoms? Has he been on any treatment on anything? I would also like to know.
Okay.
So,
Samit?
how is it going to help you? Asking so many things, how will it help you?
Sir, it would help me narrow down my differentials. Like more of frequency, urgency frequency, I will associated with abdominal pain or fever. I will think of more of UTI associated with bladder outlet obstruction. Uh, any reason for that? But in a hesitancy and more of intermittency and hesitancy, think may will make me think of bladder and the urethral outlet also, sir. The urethral structure
Okay.
helps me to differentiate my diagnosis,
Okay.
narrow down my diagnosis.
Good. Okay. Next.
Okay. Rahul, just show them.
The patient was relatively asymptomatic before 6 months when he first started developing the complaint of increased frequency, initially 3 to 4 hourly, now progressed to 1 to 2 hourly. Nocturia 2 to 3 times per night initially, which increased progressively to 4 to 5 times per night. The complaints were incidents in onset and gradually progressive. Patient complains of worsening of the above symptoms associated with incomplete voiding since last 1 month. The IPSS score is 12 out of 35 with frequency 4, nocturia 5, sensation of incomplete voiding 3. Quality of life index is 4 out of 6 and patient is sexually inactive since last 7 years.
1 second, Rahul. So, Jina, now you understand. So, first is a ODP. So, the first 3 symptoms that you got, you have to ask about the ODP, that is onset, duration, and progression of these 3
Progression
symptoms. Then the next step is you want to know about any other
or the other symptoms.
LUTS, correct? Then you will talk about the scoring. Then you will talk about the quality of life index. Then whether he is sexually active or inactive, or what is that. And now after that, all the related questions will come. Okay. So
Yes.
in exam also, please consider the same way, then you will never
Okay.
fail. Okay. Okay,
Okay.
Rahul, go ahead.
Sir, should I give further?
Yeah, go ahead.
Patient gives
Go ahead.
no history of burning, micturition, hematuria, lithuria, dysuria, pyuria, fever, abdominal pain, nausea, vomiting, urgency, urinary retention, incontinence, hesitancy, or any other constitutional symptoms. No history of backache, bony pain, weight loss. No history of bleeding disorder or blood transfusion.
Okay. That's all in history.
So we have for the, should I show them?
No. Yeah, complete karo.
Past history. Patient had history of CABG 3 years ago. He is on dual antiplatelet therapy. He also has a history of bilateral lingual hernioplasty 12 years back, and he was catheterized on during both the surgeries. It was uneventful. Family history, nothing significant. In the personal history, habits, he is a BD smoker for last 55 years, a social drinker, non-tobacco chewer, and bladder and sleep habits have been disturbed as described previously.
Okay. Can you show me the chief complaints? Okay, fine. So what do you think?
So Jena, three of you,
Yeah,
all three of you,
70.
I'm going to ask. So first you tell me what you think, what are the most important differential diagnoses that come in your mind, because you want to do the minimum investigation and then go ahead.
So 72-year-old male presented with frequency in nocturia and incomplete voiding since 6 months, and it has been gradually progressive since the onset. And history of CABG and bilateral inguinal surgery in the past, and both the times he was catheterized. Uh, and he's a smoker and tobacco chewer. So with this history, I would like to keep my differentials as bladder outlet obstruction due to a benign enlargement of prostate as my first, and due to a malignant enlargement of prostate as my second, and third will be a urethral stricture and fourth will be vesical calculus. Distribute very less.
Fine. So,
So these will be my
important
four.
three different. Okay, so the important three differential diagnoses that you come in your mind. Number one is that what is the symptomatology suggesting. So, patient has got a bladder
Yes,
outlet obstruction. Correct.
yes, sir.
That is the most important thing.
Yes, sir.
Now, it can be because of many
Yes,
reasons. And in
yes,
your view, the most important thing is because of the prostate enlarge, which can be benign or malignant.
yes, sir.
Plus, he has been catheterized 2 times.
Yes, sir.
So, you are suspecting there may be chances of stricture of the urethra.
Urethral restriction.
Apart from that, other pathology which can give rise to such symptomatology is bladder calculi, that is vesical calculi, or any calculus
Yes, sir.
disease, lower tract involving, right? And it may be because of some lower vesical malignancy also, right or wrong?
Yes.
Yes, sir.
Fine. Samit, you want to add anything to it?
Uh, no, sir. The main four, no, only this.
Fine. Okay. So, Mahendra ji, now you just, the last time also you have taught them that how to ask the questions to come to the clinical judgment.
So, sir, I think based on the history, the two diagnoses are sufficient, and
Hmm.
including all possible causes of bladder obstruction beyond the bladder neck and the urethra are
Hmm.
justified, and the sequence whatever they made, it was okay. First
Fine.
benign BPE, then query malignancy. So better it should be the answers. You said that it can be bladder outlet obstruction due to BPE or malignant prostatic lesion, something like that, and urethral
Yeah.
stricture. And I don't know, but vesical calculus until he is not having intermittent this thing obstruction while passing urine. That should, I think, we should say very cautiously. We should not say it like a DD because of outer obstruction is there. We should be say this very carefully until we can justify it. So I think three diagnosis is, if it is they can say that it is also sufficient. No need to
Okay.
add the bladder
Okay.
calculus.
Oh,
But by the
Okay.
history, I am not able to get any hint of patient having bladder calculus.
okay.
Okay. Fine. Okay, Rahul, go ahead.
Sir, we are
So
done with the
one second,
history part.
Rahul, one second. I just want to
Yes.
know because last time, na, when all the examiners were there, so they were asking us that what are the diseases that are related to hypertension, urological diseases. Last time also we had asked. So this question answer you should know, starting from parenchymal disease, obstructive disease, renal vein, the thing, renal artery stenosis, correct? Calculus
Yes.
disease. So you should know all these three, four answers. And what is the meaning of this BD smoker for last 55 years? And anything else like how many package, like, how you describe, Gina?
Sir, number of cigarettes or BD smoked per day into the number of years.
Number of years.
Yes.
Okay.
Yes.
And what are the malignancies they are related to, urological malignancies that are related to BD, I mean, to tobacco?
Sir, renal malignancy, ureteric bladder, prostate. All these
Hmm.
will be cause for all these can
Mahendra
cause
ji,
by
in your
tobacco.
view, your view, what are the main malignancies you have seen in your Tata hospital also?
Sir, link with the smoking.
Yeah, related to smoking or tobacco.
Sir, all almost I think all urological malignancies are linked with the smoking, and most common is the bladder cancer and the kidney cancer.
Yeah,
Urethral and prostatic cancer, penile cancer here are not linked with that, but these two cancers are linked with the smoking. Yeah.
fine. Yeah, so these two are very common. Please remember. Okay, go ahead, Rahul.
General examination. Pulse rate is 62. Blood pressure is normal. In general, normal. KFS score is 80. Head to toe is normal. Median sternotomy scar present.
Okay.
Per abdomen. Flat abdomen centrally on inspection. Skin bilateral hernia scar is present. No sinus or dilated vein. Rest of the examination is normal, sir, on inspection.
Okay. Next.
On palpation also, sir, no significant findings can be identified. Spine is normal, sir.
Okay. So
Why do you
Samit,
want to examine the spine? Okay, LUTS. Okay, fine. Okay, fine,
okay,
fine. Go ahead. Go ahead.
fine.
Go ahead.
So before he goes ahead, Samit, I want to know that in this case, how we will examine further.
Sir, the inspection palpation is done now. After that, the genital examination is also done. Then I would like to go ahead with the digital rectal examination, sir.
Okay. So in that, what you are expecting?
So first, digital rectal examination, I want to see the tone. Then after that, the grade of the prostatomegaly, along with the mucosa, whether it is firm, smooth, free or fixed, and any nodule which is palpable or not, or the surrounding the local mucosa, whether it is fixed or not, and also if there is a history of any stool loading which is seen, so loaded colon.
Okay. And also the sensation, perianal
And
sensation.
perineal sensations.
Fine. Show them, Rahul.
On rectal examination, no fissure or external or internal hemorrhoids. Anal sphincter tone is normal at rest and on voluntary contraction. Rectal mucosa is smooth, mobile, no induration, no tenderness. Grade 2 enlargement of prostate. Firm to hard in consistency, palpable nodule with smooth surface, non-tender. There is a mistake, sir. On the left side, it was to be mentioned.
Okay. So left side, there is a hard nodule palpable. Correct?
Yes.
Okay.
Okay,
No
so
blood or
this
mucus.
assumption is not complete. When you palpating the prostate, you have not mentioned the nodule is at which lobe, right or left. Medial sulcus is obliterated. It is you can feel it.
So he said he has forgotten
Left
to
side.
write it, but it is on the
Yes.
left side.
Yes. Always mention the side and the numbers also. And nodule, can you mention about the size of the nodule on palpation? If it can, but like 1 by 1 to 1 centimeter.
Yeah.
So probably it was 1 by 1 centimeter size of nodule, sir.
Yeah. Okay.
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 Fine. So who else? Ankit is there, na? Ankit.
Yes,
Now
yes, sir.
these are the findings. Now what you want to do?
Sir, I would like to go with some blood investigation like CBC, RFT, and along with I would like to do urine RM, urine routine with the and an extension of my clinical examination. I would like to go with the USG whole abdomen and pelvis with the Euroflow meter and also serum PSA.
Fine.
Sir, and even a bladder diary because sir
Yes,
predominantly
sir.
he has storage low urinary tract symptoms.
Good. Rahul, show them.
So these are the investigations. Basically normal, but serum PSA is 6.8 nanogram per ml. Elevated. Shall I go ahead, sir?
Yeah, show the next one. Yeah, urine routine is okay. Culture is
Yes.
negative. No growth. Fine. Gina,
We
you
have a
want to
trust films
read
of the
the
patient.
yeah, Gina, you want to read the sonography?
uh, um, the ultrasound of the prostate. But
So first say it is which type of ultrasonography?
transrectal ultrasound of the prostate. Uh, typical.
Okay, Samit, you want to try?
So this is a transrectal ultrasonography of the prostate. Here, sir, uh, the right zone, the right side, the lobes appears to be normal. On the left side, so there is evidence of hypoechoic nodule. The size is not mentioned, sir, and the contour and the contour of the prostate also appears to be normal, and there is only evidence of a hypoechoic nodule which is seen on the left uh, lobe of the prostate.
Yeah, fine. Rahul, just show them the report.
We have a report of the entire abdomen and pelvis. The truss films were given along with that. And both kidneys are normal in size and shape. Urinary bladder, it is adequately distended. The margins are smooth, no calculus or mass. Pre-void is 187, post-void is negligible. Prostate is enlarged in size, measures 5.1 by 4.6 by 3.4 centimeter. The weight is 43 grams with intravesical prostatic protrusion of 4.2 millimeter.
Okay.
Hello, how will you grade it, Samit?
Sir,
Intravesical protrusion.
so there are three grades: less than 5, 5 to 10, more than 10 mm.
Okay. So now, next, what you want to do?
Then the uroflowmetry report.
So we have not done uroflowmetry in this patient, sir.
Okay.
So then, so
PSA
after
is
PSA is elevated 6.8, mildly above the normal range, sir. So considering all the findings, I would explain the patient about the examination findings and evidence of a nodule which is suspected to be malignant. So then after that shared decision, I would like to go ahead further with to characterize the nodule and for the local staging to go with a multiparametric MRI prostate, sir.
So, Samit, I want to ask you one question.
Yes.
Suppose if I say, okay, first give antibiotic, let us wait for 10 days of antibiotic and then wait for 3 to 4 weeks, and then we will repeat PSA and then see if the PSA becomes normal. We don't want to do anything. So, Samit, what you will like to do? Is
Sir,
it okay?
if the DRE was appeared to be normal and if I wouldn't have been I wouldn't feel any hard nodule which is abnormal, then I would like to go ahead to do a repeat PSA after 2 weeks along with free to total PSA ratio. But considering my DRE findings, which is suspected to be abnormal, I would like to characterize the nodule with further investigations.
Okay, Ankit. Suppose if
Yes, sir.
patient agrees and I have done the antibiotic given and after 1 month his PSA is now 2.8,
Yes, sir.
what you will do?
Sir, I would, but I have an abnormal DRE finding as well as the trust is showing hypoechoic nodule on the left lobe. I will explain the patient about the findings and I will risk stratify the patient according to the PSA density and free to total PSA ratio I will like to do. And if
But,
it
but you don't want to do the MRI.
Sir, after that, if the PSA density is more than 0.5 or free to total ratio is less than 10, then 10%, then I would like to go for MP-MRI, sir.
And if it is not that, you will not do MP-MRI.
Uh, Sir,
Ankit,
yes,
Ankit,
sir.
when there is a positive DRE, then
Yes, sir.
don't you think that you should do
Yeah.
something more?
Yes, sir. We have
How
to
is
do.
PSA density and anything going to help? So positive. And PSA, sir, gave you an answer that it is 2.8 or something. If
Yes,
it
sir.
is 4 to 10, I can understand you read free total ratio or you're in doubt. That is
Yes,
with a
sir.
normal DRE. Positive
Yes, sir.
DRE means I think it
Yeah,
should be very
Mahendra,
clear.
Mahendra, this is what I wanted to bring out. So you just
Yeah.
explain them.
So, sir, as Hiren Bhai said that if it is a range of serum PSA is more than 4 and having nodule, there is a no doubt of doing staging and MRI and the pirates and do and further investigation. But this is a tricky situation where after antibiotic serum PSA is 2.8 and there is a nodule, right? So
Hmm.
sometime chronic prostatitis also can create these type of nodule. And with the normal serum PSA 2.8 with nodule, we are not going to achieve anything. Even though if the pirate will always be less than 3 only in these cases. If suppose that there is a pirate 4, pirate 3 or 4, then we go with the biopsy, but serum PSA 2.8, hardly 20% of the patient will having clinically insignificant malignancy like that. So in
Yeah.
these cases, better to is serum PSA, repeat serum PSA, and wherever serum PSA reaches 4, because serum 2.8 serum PSA having malignancy, it is definitely 100% will be clinical insignificant,
I think that
right?
was a hypothetical situation, sir. Just gave
No,
a
no, I just gave the
Yeah.
hypothetical
Yeah.
situation that
Yeah,
if
so I'm just saying
decreases,
how to, but sometime it may happen. Ki patient may have a small nodule, maybe DRE, it is a some maybe some small error surface over the capsule, and we labeled it as a nodule and serum PSA 2.8. So I think in those cases, just to observe the patient with the serum PSA, if serum PSA goes from 2.8 to 6, something like that, then we can investigate. Otherwise, we just have to just do a repeat serum PSA at regular interval, and we have to wait and watch. We should not do further.
okay. So you mean that if even if we palpate the nodule, because this is what we were taught, that irrespective of PSA, if you palpate the nodule, then at least you do the MRI. And if MRI is showing either PIRAD 3, 4, or 5 and palpable nodule, then better to do biopsy.
But if it is nodule like that, it is a you can easily palpable and hard nodule. Sometimes what
Okay.
happens, needles are the firm also. There are firm nodules also, firm nodules. So always when you palpate, always it is a firm nodule or the hard nodule. If it's a hard nodule, definitely it should not
Okay.
be ignored. But
Yeah.
in
So
firm
please,
nodule, instead of
yeah.
PSA 2.8, you can wait that.
So
But in
now,
exam, as
hmm,
sir said, if there is a nodule, there is no harm in doing MRI because it will say pirate 2, pirate 3. My worry is that we should not do unnecessarily biopsy like that.
correct.
So,
Fine.
Ankit, can you have a normal PSA and still malignancy?
Yes, sir.
Which conditions?
5 to 8% of the patients are PSA non-secretor, and in also neuroendocrine differentiation if the patient is having neuroendocrine tumor, round
Right.
small blue,
Any other?
or the patient is having other histological form of, apart from uh, adenocarcinoma, sir.
Yeah. So sarcoma, I think Hodgkin's.
Sarcoma, yes, sir.
Yeah.
Lymphoma and sarcoma.
Very good. Very
Good.
good.
So now, as per Dr. Mahendra Pal has suggested, if you find a hard nodule, irrespective of PSA, you must do MRI. Number one. If it is just a nodule, palpable nodule, and by after giving antibiotic, the PSA becomes normal or less, then you may wait. Correct, Mahendra? Am I clear?
Right, sir. Right, sir.
Fine.
Right, sir. Sir,
Perfect.
clinically, sir, in a practical purpose, we also have to see patient apprehension. If patient is
Right.
2.8 serum PSA, but is very apprehensive, definitely
Hmm.
we will go with the MRI to just
MRI.
clear his
Yeah.
doubt. Yeah.
Correct. Fine.
So just last
Okay.
week, one fellow known to me, to my family, He came had a normal DRE, but PSA was 21. But he had
Hmm.
severe symptoms. So I treated him with antibiotic, and now after 3 weeks, his PSA is 2.
Yes. So that no MRI.
Yeah, chronic.
Yeah,
Yeah, chronic
That's what
prostatitis. Yeah.
that's what prostatitis only. Yeah.
fine. Okay, Rahul, go ahead.
Yes.
So now in this case, okay, MRI has been done.
Gina, will you like to say something?
Yes,
Comment. You can read MRI.
yes.
We have 6 films for this, sir.
Just show them all the films one by one, and then Gina, Priya, you can decide
Yes, sir.
whichever you want to see. Huh? He will show you all
Yes, sir.
the. Yeah, is okay.
Yes, sir. So second image. The next.
Yeah, tell us. Just positive findings. You are
Sir,
not supposed to.
yes, sir. Sir, this is a T2 weighted image.
Hmm.
Uh, and peripheral zone on the right side is completely clear. On the left side, able to see.
Okay, fine, no problem. So, Ankit, just tell
Yes,
me
sir.
what is this and why you are saying whatever you are, what type of images are these? What do you
So
call it?
this is a T2 weighted image of the prostate, or T2 weighted MRI image of the prostate with bladder.
So now
With
tell us tell everyone what is MP, what is multipara, what do you mean by multipara, what do you mean by T2 image?
some multiparametric MRI is a combination of T2 weighted image with diffusion weighted image with ADC mapping on that, along with the dynamic contrast enhancement. If we combine all these, then we have this is known as multiparametric MRI. And this is T2 weighted image because the bladder in this film is bright. So that's why it is a T2 weighted image, sir.
Okay. No, but why it is what is the meaning of T2? It depends on
नहीं पता sir.
the water, na? Water content.
Water content. Yes, sir.
Okay. Fine. So now what are the positive findings you are seeing in this?
Sir, in this sir, the transition zone appears to be, sir, heterogeneously with the well circumscribed nodule seen in the left side of the transition zone, sir. And sir, in this film, the film which is being displayed over here, the peripheral zone I am not able to recognize, sir. It
Okay.
is not. Yes, sir.
Okay, fine. Rahul, just show them the report.
That's 4.
Yes, read it.
Question.
Yeah, Rahul, just read them.
Yes, sir. Moderate prostatomegaly with hypertrophy of the median lobe indenting the bladder base. Tiny ill-defined T2 weighted hypointense area in the peripheral zone on the left side at the apex level posteriorly showing marked diffusion restriction on DWI images with corresponding low ADC values and early arterial enhancement on dynamic contrast MRI. Overall Pirates score 4. Ill-defined T2 weighted hypointensity in the peripheral zone on the right side at the mid-gland level with mildly restricted diffusion on DWI without early arterial enhancement on DCE MRI. Overall Pirate score 2.
Fine.
Multiple well-defined.
Yeah. Anything positive?
So Pirates.
Pirate 4 on the left side,
Lesion
sir.
on the left side apex lesion.
Correct. So now, Gina, what we'd like to do?
Sir, PSA is elevated and MRI is showing a pirate's lesion, pirate score 4. So I will convince the patient for a rectal ultrasound guided biopsy. And because it is at the apex, if the institute is having a transperineal, I would prefer that.
So now this patient says, no, doctor, I am afraid. Why don't you do any other investigation? So will you like to do PSMA PET scan? Ankit?
So
Yes,
considering
Yes.
Yeah, Samit?
considering the PSA is in the range of 6, sir, and there is
Hmm.
one focal nodule, PSMA PET CT won't make the treatment plan change. And I'm not expecting to be a high risk disease or a metastasis. So to convince and explain the patient for the biopsy, and after that risk stratify, and based on that the
No, but
management
sir
plan
is
will be.
giving you a situation that he is scared of biopsy. So that is why sir is asking any other way to prove it. So would PSMA help? Now we don't have biopsy. He's scared of biopsy.
So PSMA can help where
That is what sir was asking. Yeah.
the uptake is seen in the SUV max.
So the important thing is for a histopathology, biopsy is must. Okay, correct? Because PSMA PET scan, right? How much you can rely on that?
PSMA PET has a sensitivity of around 91 to 94% and specificity of around 95%, sir.
So now just explain everyone what you mean by sensitivity and specificity.
Sir, by sensitivity, it means what amount of patient we can give false true positive cases. How many patient true positive cases? How many patient can be diagnosed as the true positive? And
Hmm.
specificity means true negative. मतलब, how many true negative can be diagnosed, sir? If,
Samit, can you just simplify it so that everyone who are
So,
listening?
how many of the amongst the patient, how many are actually having the disease? That is the positive, is sensitivity, and how many are not having the disease? That is specificity. So that is the sensitivity is ratio of true positive by true positive plus false negative into 100, and specificity is of false positive plus true negative into 100.
Very good. Fine. So now just show us what we have done. Rahul,
We did the biopsy of the patient.
so what type of biopsy? Gina, in your
Yes, sir.
institute, what type of biopsy you are doing? You are doing,
Sir,
the ultrasonologists are doing, or you are doing the
sir,
blind biopsies.
ultrasound. No, sir, ultrasound. We send them to the ultrasound department. They do transrectal ultrasound kind of biopsy.
So suppose if you have to undergo, means any family member has to undergo, which type of biopsy you will prefer?
Sir, I'll prefer for a transperineal biopsy because it has lower rate of infections and affects in the anterior gland can be biopsied better. So I'll go for a transperineal biopsy.
Samit, so what are
Yes,
the
sir.
different types of biopsies and what are the advantages and disadvantages and what are the prerequisites? So if any patient comes to you for a biopsy, then what are the
Yes.
prerequisite when you'll and when you will do the biopsy, and before that what you will do?
So I would explain the patient about the procedure. And so first, the prerequisite for any biopsy, first the urine culture should be taken. Urine culture should be sterile. After that, this patient, as per this patient, is on dual antiplatelet. So any anticoagulant after cardiology consultation should be stopped for adequate period of 5 to 7 days. And then after that, sir, we will before the biopsy. Usually, we at our institute we don't give enema. But enema usually given on the day of biopsy. Along with after that, we have to start 1 day prior also antibiotic with a gram negative coverage. Could be at our institute, sir. We give Ciplox and Amica along with metronidazole. And then after that, sir, take him for the biopsy. So types of biopsy, either it could be a transrectal or transperineal. Advantages for transperineal over transrectal is that the infection rate are significantly lower compared to transrectal and easy to access the anterior along with the apical zone. And perineal is not performed everywhere. Transrectal is quite familiar and which is widely performed. And other methods are it could be also MRI fusion biopsy, that is MRI with truss fusion, or it could be a cognitive fusion biopsy. Sir, initially there was also which is not performed, a transurethral biopsy was also done.
So, Samkit, you summed it up very well. Only one correction, that antiplatelets are more dangerous, so
Yes.
those should be stopped.
Yeah,
Sir,
Yeah.
I told for 7 days.
Anticoagulants, you said. So
So
mainly
antiplatelet,
yeah,
dual
yeah,
antiplatelet.
yeah, those are the dangerous ones. Secondly, Gina also mentioned about the transperineal biopsy. So there's a lot of new literature about all this transperineal biopsy. But however, in most of our institutes, we are doing transrectal. So
instance,
we have not seen
transrectal,
any uh,
transparent.
significant infection or anything. So if the precautions are taken, I think it's also equally good. Of course, the advantages are that anteriorly you can access and those things that you mentioned. So you can say whenever asked that in our institute we are doing this, but this would be better.
So what are the contraindication of doing transrectal biopsy?
Sir, active UTI when antiplatelets can't be stopped.
Uncorrected coagulopathy or painful
Yeah,
perineal
two
conditions
conditions.
like fissure in ano.
Okay, just show them the report, Rahul.
Yes, sir, the report is here. The trust-guided prostatic biopsy suggestive of prostatic acinar adenocarcinoma involving bilateral peripheral zones, with left peripheral zone showing a Gleason score of 3+4 and right peripheral zone showing a Gleason score of 3+3.
Mahendra Bhai, now can you just
Yes, sir.
guide them about biopsies and how to read and what to do further?
So, sir, biopsy में the most important thing is Gleason grade. numbers of core involved, and percentage of core involved, and definitely a type of cancer or associated any neuroendocrine tumor. These 4 or 5 things are to be seen in the HPR. Nowadays, people also do ISC routinely, routinely with the biopsy report, but it is nothing. It is only things are like BRCA mutation, something like that. They can also see in the ISC. Sometimes they report also. Uh,
Correct. So, Ankit,
Yes, sir.
now looking at this biopsy, what do you think?
Patient is having acinar adenocarcinoma, which is involving bilateral peripheral zone with Gleason grade 2, and it is involving four out of 6 core involved, and there is perineural invasion is also present, and the percentage of pattern 4 is 35%. So, summing the histopathological finding, I would like to this stratify. Patient is having since the patient is as per MP-MRI report, patient is having bilateral lobe involvement, and on the prostatic biopsy there is Gleason grade 2, and more than 50% of the core is involved, and more than and the PSA is 6.8. So as per NCCN guideline, the patient will fall into an intermediate and favorable risk group.
No, so
but
yeah, Mahendra, please.
no, I'm asking the core were 50% positive cores, na? The
Yes, sir.
cores were more than 50% positive.
Yes, sir.
So it is favorable or unfavorable?
Unfavorable, sir. Unfavorable.
So, Ankit, two questions.
Yes,
One,
sir.
what do you mean by Gleason score? And second thing is, how you classify the risk stratification? These are the two things you please explain.
Sir, Gleason score is it is based on architecture findings seen on the histopathology report. Gleason score 1 and 2 are not taken into consideration because they are considered to be low risk for malignancy. The Gleason 3, which on histopathology have glomerulite features, and Gleason grade 4 has a cribriform pattern, and Gleason grade 5 is having comedonecrosis. So while summing up the Gleason score, sorry, sir. So while summing up the Gleason grade, we take the primary most prominent score and the second most prominent score. So we combine, and it is divided into 5 group. Gleason grade 1, Gleason grade group 1 is 3+3. Gleason grade group 2 is 3+4. Gleason grade group 3 is 4+3. Gleason grade 4 is 8, and Gleason grade 5 is 9 and 10. So it helps us to predict the aggressiveness of the tumor, and yes, sir.
Good. Then risk
Uh,
stratification.
Sir, as per NCCN and as per EU guidelines, sir, as per NCCN, patient it is we this stratify the patient as per PSA score and as per clinical staging based on MPMRI report, and based on Gleason grade group, so based on biopsy report. So as per NCCN, there is very low risk, intermediate risk. Intermediate risk is divided into favorable and unfavorable, high risk and very high risk. So very low risk, all in very low risk and low risk, all these things should be present. Like in very low risk, it should be clinical stage should
Epstein,
be
correct.
clinical stage should be T1, Gleason grade should be grade 1, PSA should be less than 10, and there should be less than 3 core involvement with PSA density less than 0.15, and less than 50% of the core should be positive. In low risk groups, the clinical stage should be T1 to T2A, Gleason grade Gleason grade 1, and PSS should be 10. Yeah, all these three should be present to grade to risk stratify in low risk or very low risk group. The intermediate group is divided into favorable and unfavorable. The intermediate the in it either should be present to grade them into intermediate group. Clinically, it should be T2B or T2B. Gleason grade should be 2 or 3, or PSA should be 10 to 20. In favorable risk group, one of the intermediate risk factors should be present along with Gleason grade 2, and less than 50% of the core should be positive. In unfavorable group, more than one intermediate risk factor should be present, and it should be Gleason grade 2, Gleason grade 3, and more than 50% of the core should be positive. In high risk group, it should be clinically T3A or Gleason grade 4 or 5, or PSA should be more than 20. In very high risk group, the clinically the stage should be T3B or primary pattern, or more than 4 core involvement, sir.
Very good. But you have not explained about the T1 in the nodule. How will you consider that? Let Samit
Sorry.
answer. Samit, you answer.
Yes, sir.
About the nodule in the risk stratification. What is T1, T1?
Sir, T1 ABC, it is into T1 ABC, T2 AB, C, T3 AB, and T4 AB. So T1 is less than 5% of the involvement. T1B is more than 5% of the involvement, and T2C is on that is on the TUR, and T2C is on needle biopsy, and T1C is on needle biopsy, and after that T2A is involvement of less than half of lobe. T2B is more than half of lobe, and T2C is both the lobes. T3A is the extraprostatic extension, and T3B is involvement of the seminal vesicles, and T4A is involvement of surrounding structures involving the sphincter, urethra, or the bladder and rectum, and T4B is involvement of the abdominal, pelvic walls, or the levator ani.
Very good. So, Gina, now what is the risk stratification in this patient?
So here the primary pattern is main is 3 plus 4 7, and more than 50% of cores are positive. So this would be in intermediate unfavorable group.
Okay, so it is intermediate unfavorable group. Now what you want to do?
Just I want to interrupt you. When you describing the state, always describe like that, because it is a T2C. Both lobes are involved, so it is T2C. Okay, unfavorable localized disease. You have to mention like either localized, so in unfavorable risk, localized prostatic cancer. Yeah, locally advanced prostatic cancer. So you have to describe in this manner.
Yes.
Okay. So please note, Samit. Now can you repeat the same thing?
So it's it is involving both the lobes. So that is a T2C without any evidence of any extra prostatic extension. So it is a localized T2C intermediate unfavorable risk groups.
Very good. So now next, what you want? See, this is the way I want all of you to talk in exam. So that you are not asking for the further questions. Number one. Number two, the examiner, when he listens to you, he feels very happy, and he knows that you have read and you know the your answers well. So this is very important. Okay, go ahead. Now next, what you want to do?
Before we are going to jump to one thing, sir, I want to mention the importance of risk stratification. Stratification, when you say in the exam, it should be very impressive. It should not be in
Yeah, Mahendra,
disease.
we can't hear you.
Sir, can you hear me now?
Yeah, I can hear you.
Yeah. So I was telling about the key point regarding risk stratification. It should not be so lengthy, and one should not fumble while describing the stratification, and it should be specific, specifically for the prostatic cancer and any cancer. If the key point is for the low risk disease, which is low risk, there should be all the factor must be present. That means all factors, right? So it should be factor A and factor B and factor C and factor D. Coming to rest of the certification, they should be always any one factor should be present, either or. So the person who was describing the certification, he was just reading as it is so lengthy. What I would have said that those things ki for a disease which is low risk, it should be T1 and serum PSA less than 10 and glycerin score group 3. That's all. Is a finish low dose finish. For favorable intermediate risk, I would have said it's a T2A disease, glycerin 3 plus 4 and serum PSA 10 to 20 and or less than 50% code is positive. So you have to very specific when you're describing the certification like that in the exam.
Good. So now, Samit,
Yes, sir.
what do you want to do?
So then I would explain the patient about the all the findings, and then after that, sir, I would like to go ahead with a for a metastatic workup. So I would like to go ahead with a PSMA PET CT, sir.
Rahul, show them.
PSMA? Why PSMA not FDG PET or CT scan or whole body MRI?
Sir, PSMA, it is a single investigation, and sir, the sensitivity specificity is high, and the entire metastatic workup can be done in one investigations. And also the involvement of the lymph node is better in PET CT compared to that of MRIs.
Okay.
Rahul, just show them. Just read it. Final
Okay, sir.
conclusion.
Yeah, so this was the conclusion. Mild prostatomegaly with small focal area of PSMA uptake in the left peripheral zone at the apex level, and faint diffuse and patchy uptake is also noted in the rest of the left peripheral zone at the apex and mid gland level. No other obvious PSMA expressing lesions noted in the rest of the prostate gland. Bilateral seminal vesicles are normal. No obvious liver lesion is seen. The adrenals are normal. Small cyst in the kidney and small nodule noted in the left adrenal gland without any discrete PSMA uptake, largest of 1 by 1.6 centimeter. The rest of the solid organs and bowel loops are normal, no ascites. And few ill-defined subpleural reticular opacities are noted in bilateral basal segment. Mild ill-defined non-enhancing pleural thickening is noted in the bilateral basal segments without any discrete PSMA uptake, likely benign. No other abnormality is seen in the body elsewhere.
Fine. So Ankit,
Yes, sir.
Samit, and Jina,
Yes.
tell me what you want to do. Ankit, you tell me what you want to do.
Sir, I would like to counsel the patient regarding the disease and the extent of the disease, and I would like to counsel the patient about the management option we have, and accordingly we will plan this management, sir. I would counsel about the radical prostatectomy and also the about the radiation therapies, and I would like to tell him about the pros and cons of each treatment available, sir.
So Samit,
Yes, sir.
if you have to convince a patient for a
Yes, sir.
surgery, how will you convince?
Sir, for so this patient or
This patient.
so for this patient, I would not like to go with surgery, as sir is having multiple. Would explain him though, but he's on dual antiplatelet and there are multiple comorbidities. So and there is a small only focal area. So for to convince him for surgery, sir, I would explain him that it is the best option there for after the after surgery it achieves complete cure, accurate staging is possible, and even if post surgery there is biochemical recurrence, it can be managed by adjuvant radiotherapy compared with that of radiation, sir. And also there is also according after the surgery, his lower urinary tract symptoms also would seen an improvement.
That's all. You will not see about the complications.
And about the complications, surgery has its complication. There are high chances of post-operatively up to 5 to 10% of cases. There is incontinence along with erectile dysfunction and also wound-related complications, hernias, along with the deep vein thrombosis and anastomotic leaks, strictures, or bladder neck contractures.
But
So why the person go for
patient
surgery?
is saying that my relative is told me that it's a very high risk case, so we'll do radiotherapy. Now, what will you tell him?
Sir, we will explain him about the pros and cons of even radiation also. So here is having low urinary tract symptoms. So after radiotherapy, there could be exacerbation of the low urinary tract symptoms he's having, sir. And to achieve complete cure and accurate surgery would be the best option.
So
But
Gina,
Yes,
you
sir.
said just wait a minute, sir.
Yes, sir.
yeah,
You
please,
said
please.
the complication rates are too high. So why one should go for the surgery if the complication rates are
No,
too high?
sir, if with appropriate technique and uh, uh, minimally invasive approaches, sir, it is manageable. There are only transient cases, so there is recovery of the continence in a span of around 6 weeks to 8 weeks, sir. And along with erectile dysfunction, which can be even managed with penile rehabilitation procedure like phosphodiesterase 5 inhibitors. So with appropriate and good surgical techniques, the complications can be lessened to a high degree, sir.
So whenever you counsel the patient for surgery, you should always have a percentage. Like incontinence nowadays with the robotic surgery, hardly 1%.
1 to 2.
1
Yes,
to
sir.
two
अरे
percent.
महेंद्र,
Yes.
so can I interrupt? मतलब अभी ये he was
Ah.
saying कि with high expertise and availability of minimally invasive,
Hmm.
all the rates have gone down. So whoever was answering, can you quote any paper like that or a meta-analysis?
Uh,
They have been published with respect to prostate cancer or radical prostatectomy in open versus robotic surgery. Abhi,
no.
you talked very good things that all these things have come down because of minimally invasive robotic, no incontinence, वगैरह वगैरह वगैरह. So quote some evidence on that.
Right.
So there is no evidence. The meta-analysis says there is no significant difference.
Yes.
It's published in Lancet Oncology.
It
Okay.
is false. It is a false statement. that in open surgery he can achieve the similar continence rate
नहीं
compared
नहीं,
to.
this is exam goals statement वगैरह ठीक है, there is no evidence.
No, I'm
Okay.
just telling them. I'm telling them they
Okay.
should know that they should know
And
the religion.
secondly, you cannot talk that these things. As Dr. Mahendra was saying, you have to keep on having some specific statistics which you will quote and then justify, if at all, that why a certain technique in your hands is going to be better than certain technique in my hands. ऐसा नहीं है कि रोबोट आया तो तू एकदम सुपीरियर हो गया, ऐसा कुछ भी नहीं है. देयर इज नो मेटा एनालिसिस सेइंग दैट. लैंसेट ऑन्कोलॉजी पब्लिकेशन हैज बीन कम लॉन्ग बैक. Nobody has been able to, nobody has republished anything more. We do it robotic surgery for a different reason. I guess. और कोई comments है महेंद्र, तो तुम बताओ.
नहीं, Ganesh bhai, I 100% agree with you. So I want them to know in exam, if they have to answer that what type of surgery they will do, then if they want to say robotic surgery, then they should know why they want to do robotic surgery.
So some of the answers why I don't know, मतलब sorry, मतलब आपको पता है मैं किस problem में था.
I know.
अभी suddenly थोड़ा सा वो cool down हो गया.
No,
So I started.
you come down from the same problem.
So I have actually come back home now.
Okay.
So
After solving the
नहीं वो story बाद में बताता हूँ रात को फोन करके.
So anyway, so please understand, Samir, what
Yes.
Dr. Ganesh Bakshi and Mahendra Pal is telling you is that in exam, when you are saying that you are going to do, that is a justifiable answer. You can say, okay, I will like to do robotic assisted radical prostatectomy with my senior who is well trained in that, because now you give the reasons why you want to do it.
हाँ, कुछ तो reason दो. मतलब talk something which you have seen in robotics or in your results when you have worked in the unit. Because
Yes.
meta-analysis wise, there is no difference. Honestly, there is no difference. Nobody can challenge that. And not only that, मतलब, to be honest, even
वैसा नहीं है, टोटली एग्रीड. लेकिन रोबोटिक सर्जरी प्राइमा फेसी अगर एक आधे रेसिडेंट ने डायरेक्टली बोल दिया ना, तो दैट प्रोबेबली हैव नेगेटिव इम्पैक्ट, क्योंकि ही इज अ ट्रेनी पर्सन एंड ही इज अपियरिंग फॉर द
सही
एग्जाम.
है, बट सर फिर भी प्रोस्टेट में बोल सकता है. मतलब अपना वो लास्ट ईयर का एक स्टूडेंट
सर
डायरेक्टली
एग्रीड.
रोबोटिक रेडिकल सिस्टेक्टोमी बोला, वो जरा डिफिकल्ट है.
सर वही बोल रहा हूँ मैं कि वो अगर एग्जामिनर पूछ रहा है कि व्हाट यू आर अकस्टम्ड विद एनी अदर प्रोसीजर यू नो, एनी अदर प्रोसीजर यू वांट टू डू,
तो बताना
एट दैट टाइम ही कैन एक्सप्लेन.
Yes.
But primarily the best answer in the exam is straightforward अपना open radical prostatectomy.
Sir, I would answer in a different way. मतलब अभी I really don't know in this particular patient, but I would answer in this. Suppose I would opt for a radical open or minimally invasive approach बाजू में रखा मैंने. I will opt for a radical prostatectomy in this particular patient because of A, his life expectancy is good. Because of B, he has obstructive symptoms. Because C, apparently he has comorbidities which is very manageable for the anesthesia. And four reason may be that we do have an experience in our institution. Good outcome has been seen given settings of parameters, PSA, MRI, and somebody is talking in the background.
So sir, I am totally agreeing. Totally agreeing with your answer,
तो ये
because
answer
giving
दे
the
सकते
answer
हैं.
with justification is always better. But in spite of telling robotic radical prostatectomy in front way, they should keep the examiner should ask from his side कि और कुछ आपको आता है क्या, उसको आपका और
तो
कुछ
सर
आपके
नहीं, मैं
सेंटर में
स्टूडेंट्स
होता
को
है
वही
क्या ऐसा.
बताने की कोशिश कर रहा हूँ कि आई एम नॉट सेइंग अप्रोच. सो आफ्टर टेलिंग ऑल दीज थिंग्स यू से कि there is also a personal choice to the available to the patient. And as far as the approaches are concerned, there are two, open and robotic. Nowadays for the prostate mostly surgeries are happening robotic. अभी इसके ऊपर एग्जामिनर को जो पूछना है पूछो.
Correct. I think you very nicely put forward all
I said
the...
all those 4, 5, 6 sentences which should be said in the exam.
नहीं सर, usually examiner will ask you what you will do. That
नहीं
is the
तो
question.
सर ये बोल के छोड़ेंगे ना कि approaches are two, mostly robotic होता है.
नहीं, अगर उसने पूछा कि what are the types of surgeries available, what are the approaches available, then it is करेक्ट प्राइमा फेसी खुद होके अगर सुमोटो अगर हम सब कुछ बताना आंसर विद जस्टिफिकेशन दैट इज ऑलवेज बेटर.
नहीं, कभी कभी क्या है, डे 1 पे एग्जामिनर इंटरेस्टेड रहता है, इतना डे 2 3 पे कोई पूछेगा भी नहीं, ये बताना ही पड़ेगा.
Correct.
मतलब
So,
आई थिंक
Ganesh,
somebody
what
की
you
keep
said,
in
na,
mind.
Ganesh, what you said na, is perfect. That first of all, differentiate between you want to do radical prostatectomy, surgical management, or radiotherapy. So he has justified that, sir, I like to do radical prostatectomy in this case because of these are the 4 reasons that you said. These are the 4 reasons. Finish. Now let the examiner ask, okay, what type of surgery you like to do.
Examiner will
Then
ask either your approach or what are the reasons why are you tilting to RP.
Then you can say, okay, sir, in our institute, we are doing this particular surgery, and I will also take the senior with me, and I like to do the same. If it is not available, I will do the open surgery, or I will do the open surgery. And if the patient is opting for robotic, I will like to send him to the higher center.
वो बात भी सही है, I agree with that. तो दूसरा question to submit is that suppose if I as a patient say कि okay, I am scared of surgery. In these settings, obstructive settings, I don't want surgery. I want only radiation. So how will you line up my management?
Yes.
Uh, So then I would like to first start him on, sir, for this patient, I would like to start him first on alpha blockers with anticholinergic, sir.
For how
And
many days? And you will reassess.
uh, sir, at least for 2 weeks, sir.
Okay, 2 weeks, then no improvement.
Uh, So then, then if it is not improving, then sir, before the radiotherapy, I would like to then go ahead with a transurethral resection, and then after that, sir, plan for radiotherapy.
So when will you plan for radiation after that? Will you do anything before that TURP?
We will study ADT, sir.
ADT, very good. Yeah. So normally to make things short, what I would answer in exam is if such a kind of obstructed patient with severe LUTS is say not ready for surgery or into bracket unfit for surgery, then I would have to offer an equal treatment like radiation. So for obstruction, we would start with an alpha blocker, start with an ADT. Obviously, I'll do a uroflowmetry and I'll gauge, I'll think whether they are really going to get all right with that alpha blocker. If not, then clearly plan for a channel TURP or a good TURP. We wait for at least 8 weeks after the TURP for complete healing of the wound of TURP and then start simulation and plan radiation.
Yes.
If radiation is given on a raw wound of channel TURP or TURP, then there are other consequences. The wound may remain unhealed or in the non-healing mode, or sometimes it will cause a bladder neck contracture or something. So you please remember that. After that,
Yes.
the answer includes radiation therapy, which will be whatever, matlab, whatever type of radiation therapy that can be discussed further. I mean, I hope that
We
that's the
should,
protocol which is the best followed
yeah.
in obstructed patients for radiation therapy of prostate.
EBRT, sir.
ABM.
Any, matlab, EBRT or brachy or whatever comes last, but doing all these things, uroflowmetry, starting alpha blocker, assessing the uroflowmetry more than the alpha blocker probably, doing a channel TURP as required, let the wound heal, then simulate and radiate.
So this answer you must,
You
I will
remember
say
this
just
answer,
mug it
matlab.
up. Just mug it up. Mug it up. Write it down in your book. I request all of
So
you. This is
sitting
a
in the
very good
clinic,
answer.
I mean, all of you students, you will have to say this answer to the patient also. And this is the answer.
Yeah. So now let us find out, to talk about the different type of radiations. Yes, Samit, you know anything about that?
Either it could be a intensity modulated radiotherapy, EBRT, or a brachy. Brachy can be a low dose or a high dose rate. So low dose is implantation of the radioactive seeds within the prostate, and then deliver it the radiation, or high doses via hollow catheters through which transperineally it are introduced, and high dose rate radiation is given, and EBRT is the to the target lesion, which is around 76 to 80 grays. And there is also stereotactic body radiation therapy, where there is high doses are given in few fractions. So hypofractionation is there, which helps to there is a low rate of complications compared to the others, as it is the sessions are less. So, sir, either it could be a EBRT, stereotactic, or brachy, low dose, or a high dose rate.
So only one thing I want to know before doing brachy or all this thing, uh, do the radiotherapists do something to protect the rectum and the
So
surrounding?
there is, sir,
Rectal
there is
floor
a
spacer. They put a
Pardon?
spacer.
hydrogel spacer in between the prostate and rectums.
Yes, because I was strict, I didn't know that, and when I repeated after doing that, I found a fluid. But then I came to know, okay, this is what they are doing to protect. This is just for all of your information. Ganesh, I
Yes, yes.
sent the patient, and when they came, I said, "Arey, it's an abscess." Patient had some difficulty in passing urine, so I thought it is an abscess formation. When I talked to radiotherapist, then he explained me, this is what
Spacer.
they are doing. Fine.
So is spacer readily available है क्या sir अभी?
I think so. They are doing it.
Okay.
Okay. So shall we go for the next case then?
Okay. So I was just going to ask him what
Finish
do you
it.
mean by stereotactic radiation?
Uh, Sir, where the radiation is there is half, it's given in fractions. So high dose are given in fewer treatment
That is called
sessions.
hypofractionation.
And
Earlier, when I was learning, it was like 36 to 38 fractions were given. Okay, that same dose of 78 grays used to be divided in those many fractions. So now they divide for EBRT, I'm talking, external beam radiation therapy. So that they give today in about 20 fractions.
yes.
Okay.
So
And how will you
SBRT
follow up?
apparently has even lesser sessions, but I think we'll have to clarify that with some radiation oncologist.
They are giving 60 grain, 20 fraction, and 70 grain, 28 fraction, sir,
Fractions.
right now.
They are giving 50 grain.
60 grain, 20 fraction, or 70 grain, 28 fraction.
Yeah, so hypofractionation ka dose. Yeah, agreed. So the lesser dose is called hypofractionation.
Yes.
So there is something like SBRT. So that is what I was asking. So how does it make the difference? So when you
Sir,
talk about brachytherapy, it's usually given along with EBRT. That much you should remember. And in the high risk prostate cancers, so they give a dose of the same thing, something like 66 to 72 grays EBRD with 15 grays of brachytherapy boost in a single sitting. 15 grays, 1-5.
Okay.
So that's it, matlab. And it's done usually as a daycare procedure many times. The brachytherapy.
Okay, sir, Ankit, then how will you follow up? You have done the radical prostatectomy. We did the radical prostatectomy on this. How will you follow up?
Sir, we will after discharging the patient, we will ask the patient to come after 4 to 6 weeks for after 3 weeks for catheter removal. as per our institution protocol, we remove catheter after 3 weeks, and
Okay.
we will repeat the serum PSA after 4 to 6 weeks post surgery, sir. And
Okay.
we will see the PSA level, and then accordingly plan the further line of management, sir, whether to observe or to do something.
Suppose the
And we will
PSA
and we will
has
also
become 2 after, after surgery, after 1 month, it is 2. Now what you will do?
So this is a persistently raised PSA level. Ideally, it should be undetectable, sir, after radical prostatectomy.
After
So,
how much time?
sir, after 4 to 6 weeks of surgery, sir.
So this is, I'm saying, after 1 month.
Yes, sir. So we would like to, uh, sir. I would also like to see the histopath report also, sir. Uh,
Okay. Rahul, we have histopath report.
No, sir, we do not.
Okay.
We need to.
So Ganesh,
Yes,
can you
sir.
just explain them how to go about, depending upon the
Histopathology.
histopath report? Yeah, histopath, what are the important things they will look into and how to follow?
Okay. So, histopath report generally you will first confirm it is prostatic acinar adenocarcinoma, whatever Gleason score and ISUP grade they give. So 3+4, 4+3, that comes in GG 2, 3. That way something will be written. Other important things which we see is where we have margins positive. If margins are positive, we have to see whether it is focal or more than focal. Focal is considered, I think, less than
3 millimeter.
3
3 millimeter.
millimeters. So if single focal is there, many times they write it as unifocal. Uh, More than 3 millimeters or multiple focal is called as multifocal margins positive. Then they also report something called as extra prostatic extension. So sometimes extra prostatic extension means typically what? Disease is outside the prostate. So when the disease is seen to the pathologist going into the fat outside the prostatic, so-called capsules. Capsules I'm saying because true, false, all capsules. There is fat besides all these organs. Although you will send a prostate which looks skeletonized, there will be some fat seen on the microscope. So when the disease reaches there, it is called extra prostatic. Again, you have to check in that report margins at the place where the disease is extra prostatic. So, like some time back, when I operated, I got a report like this that 3+4 7, वगैरह वगैरह वगैरह, extra prostatic extension, left posterior, peripheral, particular zone described by the pathologist, and then niche it was like all margins are yet negative. Means probably the resection had happened wider than the extra prostatic extension. So, in a way, okay. But disease wise, extra prostatic extension is a prognostic marker. So, that is for your information. Then, second, last thing is the SV, seminal vesicle, and the vas deferens. So, sometimes you will get invasion in 1, 2, either in seminal vesicles and vas or both. So, that needs to be, again, SV is a prognostic marker for prostate cancer. And then the lymph nodes. So, lymph nodes ideally have to be sent separately, right and left. Uh, Not much literature on that individually on the right. Each zone needs to be sent separately. ऐसा एकदम जरूरी नहीं है. The count of lymph nodes should be ideally more than 12 or 14. So less lymph nodes than that seen by the pathologist means ideally that the lymph node dissection has not happened properly. Upper count is no upper count, but sometimes we have also got reports of 40, 50 lymph nodes dissected by the pathologist. So that thing is on the both sides. Surgeon doing the lymph node dissection good is one thing. Pathologist also getting out all those lymph nodes from the tissue send and noting that and seeing for disease. That is the other thing. Mm,
What
I
about
think, sir.
neurovascular bundle?
So there is not much importance on the neurovascular bundle. I mean, importance is more on nerve sparing surgery done
Hmm.
unilateral, bilateral, or not done. Because if I see nerve sparing surgery not done and the disease is much around the neurovascular bundle, means probably my pathologist is already going to report that disease is extra prostatic because the nerves are extra prostatic.
Hmm.
So they are nerves are in various layers of the fascia and outside also. So if neurovascular bundle sees disease, that means
Hmm.
my disease has come outside the prostate.
Fine.
So significance is only that. But sometimes what happens is in the prostate biopsies, some pathologist who's very clever will report that I see in a biopsy, I am saying now, in a core
Biopsy.
biopsy coaxial, I see that there is a neurovascular bundle and there is disease around that. So that should uh, tell your brain that in this particular patient, although the MRI doesn't show, there is a likelihood of extra prostatic disease. So
Correct.
that you can take thought thing then, then should you do nerve sparing on that side? Ideally, you should not do.
Okay.
Because if you do nerve sparing, then you might leave the disease behind.
Hmm.
So I think, and last is you
No.
should know the TNM staging because the last part will be something like this PT2 N0 or PT3A, or if seminal
Hmm.
vesicle is positive, PT3B,
B.
PN whatever 0, and
Yeah.
whatever.
Right. And MX, they write down because they
Uh,
don't know about the
they
metastatic
write
bundle.
MX,
Yeah.
and when I see this patient, I always write CM0 because I have done a PSMA PET CT scan and there is
Hmm.
no metastasis. So when I write the whole thing, I'll write PT3A, PN0, but CM0.
Okay. I think you explained them very beautifully about the, and this extra prosthetic and the margins
Yeah,
clear.
that
This
concept you
is,
should understand.
yes, this is very, very, because I was also confused. So once I went down and talked to them regarding all these things. Second important thing you are saying is about a fat, that even if you think that you're totally bad on the prostate, okay, still some amount of fatty layer is still there under
And
microscope.
pathologists will not mention it, but they see it
Yes,
like that.
correct, correct. I think this was you clear the concept quite a
And
lot.
another small thing which pathologists also see is called surgical incisions on the prostate. Means sometimes what happens is they will see that our robotic scissor or something has cut inside the prostate.
Hmm.
So that they come to know because those
Okay,
breaches are seen under the microscope.
okay, fine. But does it have any significance?
Ah, sir. I mean, sometimes if I cut instead of cutting outside or within the interfacial layers, at
Hmm.
some point if I cut inside, then I leave a tissue of peripheral
Tissue behind.
prostate in the patient, and I will think that I
Oh,
have done the whole surgery. But my pathologist will sometimes report or tell me at least that at this particular site, the surgeon has gone inside.
oh, okay. And the part of the prosthetic tissue has been
Then
left
that
behind.
is hypothetical. That we know then it is left behind.
Okay, okay, fine. I think, and then follow up. How often you do
So
PSA?
follow up I usually do is the PSA at 6 weeks. So that is to gauge what is going to happen. Then 12 weeks, that is 3 months. After that,
Hmm.
in the first year, 3 monthly. Second year, you take a call on the first year, either 3 monthly or 4 monthly. From third year onwards, clearly 6 monthly. Fifth year onwards, 1 yearly. And
Okay,
then technically, the guidelines do say that it is lifelong follow up
okay,
with PSA. Now, this is happens if everything is normal. Along with PSA follow-ups, obviously we have a functional follow-up. Functional follow-up again, as everybody knows, in the form of if you have done a nerve sparing, it is in that respect. And if you second is the continence or the urine control. So about the nerve sparing, there are two things. I mean, we had this onco fertility conference, and there even I learned a lot of things. Earlier, my concept was that if I do a nerve sparing or a unilateral nerve sparing, then only I should start a patient on tadalafil or sildenafil. But with what I learned from Dr. Deepak Gupte and Dr. Rupin Shah that day,
Yes,
particularly Dr. Rupin Shah,
Rupin
it
Shah.
was like this, that all the patients, we should ideally start on tadalafil or the other one. What these two drugs do is, at least till we further refer these patients ever to an andrologist, they try to keep the sinuses in the penile corpora alive. So they help keep them alive and they don't atrophy so much.
No, Ganesh, you explain them properly. See, I'll explain. What we think that tadalafil will help them in getting an erection,
Erection, yeah.
which is not so. We are going to give tadalafil, as Dr. Ganesh Bakshi said, till you do a further management. You understand? It will only help them to,
To keep
continue
the
to,
penile
yeah,
corporal
penile
sinuses alive and not
alive
going into hypertrophy. I
and
sorry,
atrophy.
atrophy.
So that is the
So,
purpose. You
and
understand,
second,
Samit? You
uh,
were saying, na, okay, you will use the drug not for the. You cannot do it. You will not give the erection because of that
yes.
drug.
I
Okay,
mean,
only will you will prevent the atrophy.
theoretically, we will probably, but this is what is the view from the andrologist side, and I also felt it is a strong view, like it
Yeah,
is
yeah, he
proper.
explained it very nicely.
Yeah.
Rupin had explained us very nicely.
And he said, like, if we have to debate on that, like he always said, invariably, a patient to have erectile function will require some more therapies, probably, or some combination therapy along with this medicine. So that is about erectile dysfunction. The other thing which we follow up is continence. We hope that the continence comes early. Now, there is a lot of literature on continence. There is a lot of personal experience with many people. So what we have generally seen with the literature is, uh, I'll tell you very few things which I think I use in my practice. Younger the patient, one thing is better is the continence achieved. Uh, First thing is, it we are discussing a case where nobody is damaging the external sphincter. Now, one big benefit of robotic surgery, and I think even in open surgeries, as far as the TMH data goes, Mahendra is sitting here, we didn't have any incontinence because of open surgeries. Important thing is not to dissect too much on the urethra further. Cut the urethra just at the prostate, ideally to give the maximum urethral length. Maximum urethral length helps in continence. Bladder neck sparing done during robotic or open surgery helps in continence. And the second is the teaching of good proper exercise prior to surgery, which helps patient learn and after the surgery. Now, I said that one sentence, that younger patients achieve continence in a better way and earlier. Elderly patients will have a, suppose, say, if I operate a 78-year-old person, I would tell him that, sir, chance that you would remain incontinent even in my hands would be something like 10 to 12%. And if I operate a 60-year-old, I would tell him today the chance that you remain incontinent is 1 to 2%. There is a difference in this reference for the simple reason that with the external urethral sphincter is a striated muscle. With growing age, striated muscle is known to lose its function, or not lose, decrease its function. It becomes aged, and it is not easy for that aged muscle to get the tone back and get the continence. So, a 78-year-old patient will have to work quite a bit on his Kegels exercises. A 60-year-old will work and get the return of continence very fast. Um, those who are muscular people, I have seen them continence happens absolutely fast. Like 2, 3 patients I've seen have become continent after 2, 3 days only. So I think
Yeah.
all this is with the follow-up. I
Uh,
mean, and secondly, incontinence we record usually in the number of diapers or later on in the number of pads used. So there's one last question here is, how much is acceptable continence or acceptable incontinence. So apparently, many papers define use of one pad per day is acceptable. So the details in that is continuous incontinence with one pad is not acceptable, but many of these patients will reach to a stage where they will have some stress urinary incontinence, 2, 3 drops sometimes when they cough during the day. And that is why they need this one pad. So that is why one pad definition is acceptable.
I agree with you. I have seen so many patients. They said, "No, we are there absolutely continent, but once in a while, and they don't
Um,
like it, so they like to wear the, it's like
so
an
that
agent."
is why, sir, that definition has come that that is acceptable.
Correct,
Ganesh
Means
bhai, what
earlier
is
our
your
concept was that ki nothing, I mean, pads are not acceptable. Means there is incontinence means incontinence.
correct.
Ganesh bhai, what is your view about this biofeedback, which is nowadays that fellow keeps roaming around?
So there are two views about it. If you say theoretically, and if that therapy is available with my physiotherapist in the hospital, it is good because biofeedback is a form of giving advanced physiotherapy. So it
Correct.
will obviously help us to give the best possible exercise training to the patient and expect better results. Having said that, if you spend a little time with the patient in the pre-op period, post-op period, and at the first follow-up of 6 weeks and help them understand what is the exercise you want them to do exactly. So that actually almost equates with that. I mean, I they meet me every week, twice, thrice, but I think I've given them two patients till in the last 3 years.
Right.
And they were all these patients whom I had referred to them, where actually one was young, but just not willing to do Kegels exercise. And the other was slightly elderly, about 73, but like used to smile at me and do some exercise, but not the proper exercise. So what we routinely have started doing now is to check how people do exercise. And when they come initially at a 6 week follow up with a PSA, I usually tell them to sleep in the Sims position, insert a finger in their as a DRE, and tell them, okay, now you do the exercise and show me how you are doing the exercise. So it is very easy to understand with that if as the lever trina contracts and what they do. Many times the patient sleeps there and just takes a deep breath. Nothing happens at the lever trina level. So I know that in spite of all the teaching, this fellow is not doing any exercise. And typically at 6 weeks, these people are almost totally incontinent. So you try to teach them better exercises at that time, and then probably you get a good outcome.
So I think you have explained them very nicely that it is not only the PSA that you have to follow, they have to about the continence and about the sexual activity. Also, all these things are very important. And this is what I think they should answer in exam if if they
Yeah.
want to correct. And even in I think in our practice also we must categorize when the patient comes, we should have that some form with us where we are asking them not only about the kind. We are just happy. How are you? Continence, very good. PSA, one day it is zero or something, and we are very happy. But as you said very rightly, we have to see everything. That is very important. So,
So,
any
sir,
questions? Yeah, Bolo.
we'll have to ask them what is BCR
Yeah,
and what is PSA persistence.
Samit.
Yes. So biochemical recurrence there are is different for the post radical prostatectomy or post radiotherapy. So there is two consecutive rise in PSA more than zero point 0.2 is considered a BCR for radical prostatectomy, and in for radiotherapy it is either as per the Astro or the Phoenix, Arizona definition. So Astro is the two consecutive rise in PSA 6 months apart with backdating midway between the first failure and the nadir PSA. And for the Phoenix is the nadir plus two criteria.
Hmm.
Okay, so we
And
follow the Astro Phoenix combo definition, which says the same thing. 2 plus Nadir and rising.
Yes.
That's the RT related thing. And in the surgical, what you said, zero point 0.2.
Yes, sir.
So the AUA believes it 0.4. I mean, we follow the European definition, which is zero point 0.2.
Yes.
So what is PSA persistence?
PSA persistence is defined as PSA more than equal to zero point 0.1 nanogram per ml within 4 to 6 weeks of surgery, sir.
And what does it indicate?
Sir, it indicates either persistent local disease, or there is pre-existing metastasis, or
Or
there may,
occult metastatic disease?
yes, sir, or benign prostatic tissue is left behind.
Residual
But
tissue.
benign prostate tissue, actually the PSA of zero point 0.1 is also quite high. Matlab. So benign prostate, na, if we leave behind benign prostate, the PSA is usually in the negligible range only.
Okay, sir.
तो
Okay, then
सर मुझे पता नहीं आगे कितना जाना है, मतलब आप ही
नहीं
ले
तो
लो आगे.
नहीं अभी यही केस में आप जस्ट पीएसए के बारे में सब पूछ लो ना, just ask and then we finish the case. Then next time we are going to do
I was
locally
hearing
advanced.
initial part, मतलब PSA density वगैरह महेंद्र सिखा रहा था. महेंद्र, you are there? Mahendra has left already.
And just
Okay. So PSA के बारे में पहले क्या हुआ है इनका?
नहीं, nothing much. I don't think so.
So what is the importance of PSA indices is one question. PSA indices means various indices are there. PSA velocity, PSA doubling time, PSA density.
So PSA indices help us to risk stratify the patient whether
Oh.
in a PSA range, in a gray zone of PSA. It helps
Oh.
us to,
Sir, when it is PIRATS 3, then we can uh,
whether we can go for biopsy or not. It helps us to decide well, PSA density, and help
Mhm.
us to decide for going for trust guided biopsy or not.
So that you are saying about PSA density of 0.18 and above
Yes.
with PIRATS 3. Suppose if I say PIRATS 2 है, PSA density 0.48 है, 48, तो क्या बोलोगे? एकदम ऐसे मतलब इसलिए ये ऐसे बोलने से ना, यू हैव टू टॉक वेरी प्रॉपरली देन. जो बोला वो सही बोला, बट देन आई नो दैट नाउ कि पायरेट्स 1, पायरेट्स 2, पायरेट्स 3, 4, 5 में यू हैव रेड ओनली दैट वन लाइन, पायरेट्स 3 वाला.
Sir, PIRATS 1 and 2, it is divided either low risk, if based on risk stratification tool used for like PSA density and PSA kinetics. If it is PIRATS 1 and 2 with low risk and there is no family history, then we can and the PSA kinetics are within normal limit, we can omit the biopsy.
So
If
you just
there is
said PSA kinetics are within normal limits. वही क्वेश्चन था पहले. So what is PSA kinetics, PSA indices क्या होते हैं?
sir, free to total ratio, if it is less than 0.10, is less than
Free
10%.
to total ratio is free to total ratio.
Yes.
That is indicated in the PSA zones of 4 to 10.
Yes, sir.
so
Correct.
the
Yes. Yes, sir.
So suppose मेरा PSA 11 है, तो कंसेप्ट ही निकल जाता है वो. तो what is PSA velocity? What is doubling time? Anyone can answer. ऐसा कुछ नहीं.
so the
So
rate of
these are
change of
specific indices which were devised to help us whether we are suspicious of prostate cancer or not. So this was mostly these PSA related indices were used in the era when MRI was not so special, or we didn't have extra sensitive PSA assays. So today we do use them in a very loose way. So PSA velocity, that is the PSA increase per duration of a year or something, we hardly use today. At the most, we have certain PSAs like age specific PSAs are slightly important. sometimes we would see the PSA density because we will have a high PSA but a very big volume of prostate. It would be still benign at times. That is what you were talking, matlab. Pyrids 1, 2, 3. We are not talking pyrids 4, 5. Then one very important PSA index is PSA doubling time. So PSA doubling time has still retained its very big value. And maybe it has retained the value in, I think, two things in decision making. One is something what we call non-metastatic CRPC, non-metastatic CRPC setting, and the second is in treatment of
ECRC.
hmm,
Risk
One
stratification,
in
sir. Low risk and high risk.
post radiation
correct.
also.
So basically, they have literature has been studied and found that 10 month is a l- good limiting interval. So people who have PSA doubling time less than 10 months and above 10 months, they behave quite differently in outcomes of prostate cancer. If you go below 10 months, as you go below, the disease starts getting much more aggressive. That much you remember. So about PSA, doubling time is one of the most important PSA index today. The remaining things we hardly use. I mean, you should know, but that's more important. There are then certain tests like 4K score test, which is not available in India yet. So that is also a test which is using PSA Pro, PSA HK2, and a calculation of that
Okay.
mathematical calculation, which tells us about how good is the
Probability of picking.
suspicion of diagnosing prostate cancer. 4K score test is also very good in telling us about certain prognostic features in prostate cancer patient. So no other test has got both these values. There is something called as a prostate health index also, which is also a separate test, which is made available in India today by Abbott. I think it's done also in Tata Memorial Hospital actually. It has something like a percentile value. 34 or 40 is the percentile, which is the limiting percentile. So anything which is above that is something like, again, more favor in diagnosis of prostate cancer. Like 4K score, PHI does not have a prognostic value. उसके बाद PSA का कुछ है नहीं. There is some markers like urinary biomarkers like PCA3, which also is not available in India. It is said that PCA3 is quite a strong diagnostic test and it can actually give a indication of prostate cancer. So it is a urinary RNA based biomarker test. और आई थिंक ये पार्ट 1 लिखा था, तो नेक्स्ट टाइम क्या डिस्कस करने वाले सर?
Locally advanced and metastatic, and then I will try that him to Amandeep if he can come. That as usual, like half an hour, 45 minutes. What do you
सर
say?
ये थोड़ा सा कंसेप्ट ऑफ बीसीआर भी डिस्कस करना पड़ेगा नेक्स्ट टाइम. लाइक आफ्टर रेडिकल प्रोस्टेटेक्टोमी देयर इज अ बीसीआर, व्हाट कैन बी डन, and after
Okay,
radical radiation therapy there is a biochemical recurrence, what can be done.
okay. So we will continue
Now
that.
that can just take 5 minutes, but I think we can continue next time on that. क्योंकि अभी
Okay, so we'll start with that, and then we will
हाँ, I
go
think
on.
whoever is joining can also read that, because there are studies about to give a background, it is adjuvant radiation therapy, or in some words called as salvage radiation therapy when it is too late. And what we practice today is early salvage therapy. So there are studies with respect to adjuvant, there are studies with respect to early salvage. Early salvage में there is a meta-analysis, yeah, and radicals वगैरह भी है. So all these things are there. I mean, you should know
Okay,
this because when you reach radical prostatectomy, somebody is logical to ask you as an exam, okay, अभी PSA बढ़ गया तो आप क्या करोगे?
right,
I mean, maybe we should discuss with radical prostatectomy today only, but ठीक है, we can discuss next time. It's 11 o'clock.
fine. No, so we'll continue with this first 10 minutes, finish it off, and then we'll go ahead.
चलेगा
Okay,
सर. Okay.
Ankit? Samit,
Yes, sir.
Yes.
Yes, sir.
Gina, be prepared.
Yes,
Okay.
sir.
Yes, sir.
Yes, sir.
Good, good. Oh, I'm happy all three of you are answering very well. Excellent. Just
Yeah,
continue.
I think you're answering
Sir,
very well.
sir, I
Yeah,
have
and
one question.
yeah.
Okay, go ahead.
Sir, you have told about positive surgical margin. Sir, in the latest 2026 EAU guideline, the size they have mentioned is less than 1 mm and more than 1 mm, sir.
So that's what I
And
mean. I was thinking that only. My pathologist
uh,
also writes the same thing. Less than 1 millimeter. We take
yes,
it
sir.
as that only.
Yes, that's why I got confused whether it is 1
So
mm or
earlier
3
literature
mm.
somewhere little long back, it was 3 millimeters.
Okay, sir.
Fine. Okay. So
Okay.
thank you very much.
Good
We
night.
continue next time. Okay.
Thank you, sir.
Good night.
Thank you, sir.
Good
Good
night,
night.
sir.
Good night.
Good
Thank
night.
you, sir.
Just tell all your friends that exam has been postponed. Now it is in end of September. So they can join. There is enough of time, and all these things, what you listen, you will remember. You
Yes,
understand?
sir.
Once you
Yes.
listen to all these things, write it down. I am 100% sure you'll never forget in your life. And this is going
Yes,
to
sir.
help you in your exam. Just by reading, you are not going to achieve what you want. So tell your friends also to attend these clinics. They are of a great help, even for the theory. Okay? Okay.
Yes, sir.
Yes.
Okay.
Good night.
Good night. Good night.